Hello, and welcome to Ethics on Call, the podcast of the Center for Theology and Ethics in Catholic Health. I'm Tom Bushlack.
And I'm Dan Daly.
And today we're going to take up a critical engagement with some recent scholarship on organizational ethics, especially as it relates to some best practices in healthcare and for the healing ministry as well. So, 3 articles that we'll be referencing throughout this podcast that will be linked to in the show notes. The first one is a chapter from Christian ethicist Dan Finn on social structures from a book that was published in 2020. The next one is an article just published in the last year from Ireland Miller called Building an Ethical Hospital Culture, Integrating Ethics into Organizational Frameworks in Healthcare. And then another article also from 2025, co-authored by Sarah Combs, Ariana Thompson-Lestad, Kevin Dirksen, Kayla Tabari, and Seth Holmes. And that one is called Incorporating Structural Competency into Clinical Ethics, Piloting New Bioethics Education. So we'll be referencing those. And again, they will be linked in the show notes as always. To get us started though, Dan, I know your work has engaged with and been influenced by some of this work in social theory and critical realism in particular, and analysis of social structures and culture. So can you tell us a little bit about how you first learned about this tradition of inquiry and then how you've placed it into dialogue with Catholic social teaching, virtue ethics, and healthcare?
Yeah, thanks, Tom. So, years ago, I wrote on structure and virtue. I was really interested in how the virtues, the character traits that we acquired were influenced by the structures that we participated in. And at the time, I was, on 2 ethics committees at different hospitals, and then I started to make some connections between structure and healthcare. And it was with this one kind of conversation that I had with someone that really illuminated it. So I was on these 2 different hospital ethics committees, one of which did not have many ethics consults at all. Very few ethics consults, very few end-of-life ethics consults. The other hospital had a lot. And I went to someone who knew both hospitals well, and I said, "Why do you think that is? Why does this one hospital have all these consults and the other one doesn't?" And they said, "Well, look, the one that doesn't have as many consults has a palliative care service. There are palliative care docs. They have a palliative care approach. They have a way of addressing patient needs at the end of life that other hospital that lacks palliative care services does not have."
Mm.
And so I started to think, well, here we have patient outcomes, patient well-being being really directly affected by decisions that are made at much different levels. This is not a bedside problem. It appeared to be a bedside problem on its surface, right? You've got these cases with patients, families who wanted more care for their loved ones than was medically indicated, which was usually the case. The issue was a structural issue. It was that there was a lack of a structure to promote the well-being of patients at the end of life in that hospital that lacked palliative care. And so, because the patients in that hospital where they lacked palliative care, their options were either life-sustaining treatment or really nothing. There was no real good alternative. So, of course, everyone went with a life-sustaining treatment because nothing seems like a complete failure of your care for your loved one.
Right.
But in the hospital that had palliative care, it was, well, we could continue to do this life-prolonging therapy, or you could use palliative care that could prolong for a while. It doesn't. We can still use palliative care, as we know, can be used with life-sustaining and prolonging therapies. But often patients would use that palliative care in a hospice setting, or even if it wasn't hospice, it was kind of within the hospital. But there were options. There was a good option. There was a good alternative to doing everything. And I actually brought the story to Dan Finn, you just mentioned his article, and he started to help me think it through. We were at a conference, and I told him the story, and he said, "Well, this is a huge structural issue." And he had already begun to teach me some of this material, but that was pretty eye-opening and made me really begin to reflect on the influence of structures at the bedside level, at the patient level.
But
But
Can I
Yeah.
jump in on that? I think
Yeah,
something
please do.
that strikes me as I hear you tell that story again is, presumably the members of the care team at both hospitals were equally trained, educated about medical options, equally cared about their patients, had the same, rough level of competence, but a structural difference meant that there were different choices available to them that then they could offer to patients. Um, so that it's just interesting because we'll talk more later about structures and how moral agents play out their roles within structures. That's a really illuminative example.
Yeah. Yeah, yeah, it was fascinating. It kind of has stuck with me. But, having Tom, having had a career in Catholic healthcare, I'm curious, if you have had any experiences, have heard of things in the field that resonate with you in terms of how organizational structures influence the kind of care that's provided, not provided, et
Yeah.
cetera.
Yeah. There's a line in the Ireland Miller article where she writes that ethical challenges frequently arise at the crossroads of clinical care and financial management. And just in our last episode, for those who listened when we interviewed Laura Webster, she mentioned an article by that appeared in Health Progress on why we should stop saying no margin, no mission. But the reason or what most people would want to say is, it's got to be both. It's got to be margin and mission for the ministry to be viable. But the reason that phrase hangs on is because that is often where I think people working in the field, as it were, see the realities of how organizations are structured within our not just our U.S. healthcare system, but even in the economic system, broadly understood, can start to push decisions in a particular way that might be in tension with certain mission critical commitments that our health ministries have because of our Catholic identity and that commitment to serve the poor and the vulnerable. And again, I saw that in general come up in a lot of ways. I think an area where I saw that and many ethicists and mission leaders and providers and administrators will recognize this as a recurring theme. Questions around performance metrics and compensation structures for providers or clinicians um, often become points of conflict within individual ministries. And again, I'm referencing the Miller article in particular. She looked at two real life case studies and said, there's kind of three approaches that were necessary to transform the ethical structure that enabled for more ethical possibilities among the coworkers. And one of them was leadership training. The other one was evidence informed decision making. And then the last one she mentions is transparent performance metrics. Um, and I just saw that over and over again, where, again, an anecdotal thing that somebody told me as a leader one time is, about the time let's say you're in a leadership role within one of our ministries and you're rolling out some new initiative and you've got performance metrics around it, because that's a standard best practice and something that has its place. Uh, that about the time you think you start really getting sick of repeating yourself over and over again when talking to your coworkers is probably about the time that they're now just starting to listen and kind of get the point. And that whole piece around transparent performance metrics, I think, is really key and can go a long way to not just creating a cohesive work environment, but even things like a sense of moral distress or burnout that clinicians can find. There needs to be that clear transparency and alignment in order for people to feel like, oh, I'm really contributing, and I see how this is really valuable, because if I do X, Y, and Z that are on my performance metrics that affect my compensation, I can also see that means that people in my community are getting better care or more access. And when when clinicians, because they're really passionate, committed people, that's why they got into medicine. When they can align that, they feel good. And when it feels out of alignment, that's where frustration can come up. So I think there are a lot of places where the pieces that we're going to talk about really kind of connect with real life practice.
Yeah, that's a great example of the need for transparency, so that people can see uh, that how one gets evaluated is in line with the mission, right? I mean, ultimately, we'll talk about that. That all of the kind of rewards and penalties that exist within organizations, if we're talking about Catholic healthcare, should align with the mission.
Yeah.
And it's not easy to do, but it's a worthy endeavor for those who have that as their administrative role, to align all of those enablements and rewards with the promotion of the mission, which we can talk about in a broad way. But
Yeah. Yeah. Yeah.
that's a good point.
I think the Dan Finn article, I think, provides sort of a good big picture hermeneutic that we might use throughout this episode, in the way that he and others, including you, have engaged with critical realism. So do you want to start, maybe give like an overview of his discussion of structure and moral agency and roles and culture? And then I think that will set us up to talk about some of the more like case studies and practical things in the Ireland and Holmes et al. Article.
Yeah, I'd be happy to. I mean, it's fairly complex on its surface because it's very theoretical. But once I'll try to illustrate with some examples that I think will make it easier to digest. If you read Finn's work, he's very clear, but he's drawing on a really complex social theory called critical realist social theory. Interestingly enough, many social theorists have tightly connected critical realism with Catholicism for a
Oh.
variety of reasons. Because I mean, the former president of the Pontifical Academy for Social Sciences, Margaret Archer, was a pioneer in critical realist social theory. So if you look at the Pontifical Academy for Social Sciences, it's filled with critical realist scholars.
Hmm.
So when social theorists look at critical realism, they think Catholic. And it
Interesting.
and I could explain, there are
Yeah.
reasons why. One reason is that social theories are supposed to solve the problem of structure and agency. What's the relation of a social structure and my agency? Do I actually have free agency, or do the social structures determine my actions? And what critical realism essentially says is that you're free, you have full moral agency, you have free agency, but structures influence you. So critical realism sees that both structures and agency are real. They're interconnected, and you're free but enabled and constrained within
Hmm.
any social structure. So we can think about examples that I'll go through. But Finn's really a pioneer in this, bringing this to the theological community, bringing this, really connecting this social theory with social ethics, which he does in a number of articles and books that we can link in the show notes.
Yeah, I
One,
think,
yeah, please,
sorry,
yeah.
just to, as you're setting this up, and then we'll get into more of like the definitions of some of the terms and how they're being used. But and Dan was direct in addressing this as he developed this work. So many people involved in the work of Christian ethics on the academic side, or mission integration or ethics in healthcare, are very interested in social change. And that comment that he makes, and I've heard others say, is, if you don't have an account of what social structures are and how they change and what role we have within that, as moral agents, it's really hard to advocate for social change in any kind of practical way. And for myself, as I started getting the basic concept, once you kind of see how it all works together, it's like you just start seeing it everywhere. Like, oh, my whole life is made up of me in different roles, either being constrained or enabled to make different choices, and having different consequences for those choices. So, which is to say, I don't. And what I love about critical realism is it affirms like you still are you, and you are a full human person with human dignity, and you have full moral agency. But that agency is never exercised in a vacuum, and so it's going to be influenced in different ways based on roles and relationships and structures and incentives. So I don't know, would it maybe be helpful to start with how critical realism defines structures and then go from there.
Yeah, I mean, this is essentially what Finn does in that piece that we're linking is he introduces a lot of these concepts. I mean, what a structure is basically a web of relations among social positions. So let's think of a hospital. In a hospital, you have all of these social positions: patient, physician, nurse, CEO, CMO, other administrators, ethicists, mission leaders, right? All of these different folks. Those positions pre-exist, and then you step into them, whether you step into the position of patient when you walk through the door and you have, some kind of a health need, or you are offered the position of physician and you become a physician, right? Everyone then has there are expectations that are bound up with those positions, right? Patients are supposed to wait and be respectful and uh, more or less when the therapy that's being offered is effective, go along with that and not be
Hmm.
overly difficult if that is a therapy that's beneficial. So the physicians, they're supposed to follow standards of care. They're supposed to again, you talked about performance metrics, right? They're supposed to look at the performance metrics and try to follow those. And the thing about these social positions that we enter into, these roles, is that if you don't do that, let's say you're a physician who does completely ignores these performance metrics, you won't be a physician for long. So you only stay in the position if you follow the expectations of that position, right? So what do? We typically go along with the expectations of the position, with how what we're enabled to do. We don't do the things that we're constrained to do. We typically will do the actions that will be rewarded, whether that's with a promotion, a raise, respect. We typically don't do the things that are going to penalize us. So what critical realism really explains is why people tend to follow these pre-existing structures. Because you're still free, but you look at the enablements and constraints, the rewards and penalties, and you think, I'm going to go along with what they want me to do. If you don't, you won't be in that position for long, or you'll be severely penalized such that you won't like those penalties. So what it does is it explains why people do what they do. It's not the only explanation because, as you noted, we still have free agency, but it helps to explain why we act in certain ways. And so what it ultimately does is, I think for the ethicist, is it turns our focus away from the individual, not fully away, but it turns our focus both to the individual and to the structure. Because if you want people in Catholic healthcare to do the right thing, and the structures don't enable them to do that, or they penalize them when they do the right thing, guess what's going to happen? They're going to have a harder time doing the right thing. So we need the
Mhm.
structure to be aligned with those values that we hold dear, the structure to be aligned with the mission. And I think that is the real takeaway that I have from Finn's chapter is looking at how structure influences our agency. And so I don't know if there was a takeaway that you had there, Tom, that you want to share.
Yeah, there were a couple. I think one where a bit of a light bulb went off is Finn and I think other critical realists mentioned that the people with the most privilege in a structure who are most benefiting from the things that it enables or facilitates based on the way that structure has been organized, are the least likely people to want to challenge that system, or put alternatively, uh, to think about in terms of Francis's language of the poor and the marginalized being uh, what's the word? What protagonists in their own transformation and transformation of social structures, because Catholic social teaching has used that language of structural evil for at least since the time of liberation theology, bringing some of that language in. And this is, I think, an evolution of our understanding of what that means, so that it kind of makes sense why the people that have the least amount to lose are the ones who are most likely to bear the consequences of shaking things up, of not following the those enablements and constraints set up by the structure. Um, so that was one one piece that kind of grabbed my attention. Did you want to look like you were going to say
Yeah,
something
I
on that?
think it makes me think that when you buck the system, when you buck the structure, um, you're going to suffer penalties. I mean, I think of all these calls for us to be all more ecologically virtuous, which wholeheartedly support. Right? We should live simpler lives and do all this. But the fact of the matter is, there was a study that was done years ago that said that even persons suffering from homelessness in the United States have a carbon footprint that is twice the global average. Now
Mm,
think about that. Person
wow.
suffering from homelessness. So the only way for us to get to the global average or below it is to live completely off the grid. Now, if I were to live off the grid, I wouldn't be able to do the work that I do. My kids their educational experiences would be really different, right? There'd be enormous penalties that we would suffer to do that.
We would not be
Um,
podcasting.
I would not be podcasting because yeah, I guess this takes up a lot of energy, as we know.
Yeah.
So the point is that these calls to virtue, while important, have to be joined with structural transformations as well, because we all know that we can't individually solve the problem of climate change, but only together, right? So I think it shows us, and that's an example that I think is just resonates so deeply with anyone that I've discussed and use that example. People, they get it. They
Mhm.
see, yeah, I mean, I do feel constrained. And I'd like to be enabled to live a simpler life or and a life that has a lower carbon footprint, but it's just not. If I want to travel to conferences, I have no choice but to get on a plane that takes up an enormous amount of CO2, right? That uses a lot of CO2. So it would be great to have other forms of transportation that are cleaner, that would allow me to still be with people and engage and encounter others. But
Yeah.
we're not there yet.
Yeah. The other piece that it's a little bit in the background, Dan Finn mentions it in his article. Critical realism talks about these structures as emergent properties that exist at a level higher than the individual. And by higher, they don't mean better, or even overpowering, right? Because it maintains the capacity for agency and autonomy. Um, but I think that it's important to keep that in mind because certain strands in our own tradition of social teaching or transformation of structures would say that, you know, social evil or structural sin is just the accumulated effects of individual actions. So everything can be reduced to just individual actions. But the example that you gave about climate change and the environment is a good one because no one person has or even collectively has sat down to say like we want to make it impossible to get have not have a huge carbon footprint, but collectively once that emerges and then once it emerges it creates again constraints, punishments or opportunities. And but the other piece that I want to ask you about, because you've worked a little bit more in this area, is you could take that piece and be like there's like a cynical conclusion that you could take from that. Well,
Yeah.
these structures just exist. There's nothing I can do about it. So I'm not going to be an environmentalist. I'm not going to care about the environment. And I mean, those are options that we see live in our culture today. Um, so what's the upside of engaging with this that enables us to use that word? If we put on this lens to create sustainable change or help to create structures and organizations that promote virtue?
Yeah, it makes me think of the Ireland Miller piece where, what she does is she writes about organizations. And so,
Hmm.
an organization is a social structure that has specialized roles and authority positions. So like anyone listening to this exists within an organization. There can be more diffuse social structures, but we're all members of organizations, the Center for Theology and Ethics, all of the different health systems that we have at
Hmm.
Catholic Health. Those are organizations. Um, and so, the question is, how do we, given that we have limited agency and we live within these organizational structures, what do we do? And I think what the listeners to this podcast, what I think about that we could do is culture is intimately intertwined with structure. So the critical realist account of structure typically is that a culture is composed of the ideas that we endorse and enforce.
Mm.
So Catholic healthcare, part of the culture of Catholic healthcare is we endorse and enforce the notion of human dignity. We say that people are transcendently valuable, and then we enforce that. If someone treats someone as a thing, there's some kind of a penalty attached, right? You'll be reprimanded. You could be fired. If you use racist language, right? You could be that's to not respect the dignity of someone. You'll be reprimanded, if not terminated. So I think culture culture really is a producer of structure. There are other things that produce structures, but I think making sure that the culture is aligned with the values that we hold. And, again, ethics, mission leaders, CEOs can all be leaders in culture, and that can find resonances in structure. Ultimately, what you need or want is an alignment of culture and structure. I'll give you an
Mhm.
example, Tom, of a culture that isn't always aligned with a structure, and it's one you'll be familiar with: higher education. So you
No, that's not aligned.
so what higher education institutions will often say is teaching is the most important thing we do, right? Teaching our students. And then you look at the structures by which professors get hired and then especially tenured. And they'll say, "Oh, we're going to evaluate service and teaching and scholarship." And I've been around long enough to know that I've never known anyone who's lost tenure based on teaching.
Mm.
I've known a lot of people who have lost tenure based on lack of publications. So we say what the culture is, the idea that we endorse is we care a lot about teaching. Teaching is the number one thing we do. And then you look at the structure. Who do we promote? Who do we reward? We reward people who write a lot. Now, I am in favor of that. I think it's absolutely essential that we produce scholarship, but there isn't a balance there. It's disproportionate in
Yeah.
terms of what we say and then how we structure it, right? So that when you enter the position of professor, the expectation is you're going to get rewarded for writing, not for teaching well. And the
Mm.
people I know who teach well, and I think the vast majority of professors do it not because they're going to get rewarded for it, but simply out of the goodness of their heart.
Mm.
And I think what we need is that we need the rewards to align with our values. And you really know what you value based on what you reward and what you penalize. Just think
Yes.
about whatever the organization rewards or what it penalizes, and that is what it values.
Hmm. Well, I'm thinking of parenthood too. Like
Yeah.
how do you the social structure of the family and what that classic like do as I say, not as I do. We all want to model the virtues that we want our kids to most
That's right.
embody, but they're from a very young age they can pick up on that if that's not aligned. And we see the same thing in organizations. And so this is where I think it gets really interesting, and we're getting into some great examples. Is I think Ireland says this directly. Certainly, Dan Finn and others would say, um, virtuous organizations that are really aligned, where their culture and their structure and their policies are really aligned to incentivize doing what is most mission aligned, and disincentivize or penalize moving outside of that. Um, they don't really happen spontaneously. They
Yes.
require a lot of um, commitment and intention, and that never ends. Like you don't ever get to a point where it's like, okay, this structure is now self-perpetuating without good leadership and people participating in that. And the other piece that I think these articles start to get at is uh, you talked about roles having different enablements and constraints. And, the higher up you are in an organization, the more power you exercise in terms of creating or changing um, incentive structures, right? So whether that's if you're in the HR department and you're looking at how do we evaluate coworkers, do we include an element in there of how mission aligned your decisions are as a leader, or do we leave that out? And that's going to impact how that culture self perpetuates. So leaders, it seems to me, and I think this is what the theory would also say. Correct me if I'm wrong. That leaders and high level administrators um, have a, I don't know what the right term is, like a higher proportion of responsibility and power to influence how those structures are organized. Is that an accurate way of saying it?
Yeah, so I think you're absolutely right. So certain positions have more. There's a hierarchy within every organization, and so certain positions have more power than others to enforce the structure. Right? If you have the power to fire someone, right, then you've got an enormous amount of power over others, and that you can choose to emphasize one aspect of the structure, one aspect of the position description over others. You can change those descriptions. You talked earlier about metrics. What are the metrics? What are we measuring?
Mhm.
Um, as you noted, the Miller piece, she writes about integrating ethics into performance evaluations, which I think is absolutely essential for everyone. Because even though CEOs have more power than anyone in the organization, CEOs themselves are constrained.
Mhm.
They live within a structure. They're not completely, I mean, they're free, but they're constrained and enabled. They're going to be evaluated too. The question is, how does the CEO get evaluated? Is it just based on financial performance and growth? Or is it based also on living out the mission? How many, the care for the vulnerable, the marginalized, the poor in the community? Have we expanded access? I mean, I think in Catholic healthcare, the CEOs, and I've heard stories of this, they have that. Many CEOs do have that as a part of their performance evaluation. So they are incentivized, even though they want to do this out of the goodness of their heart. It's also wise to structure this, to build this into the position description and evaluation. And
Mhm.
I think to be more mission aligned is to make sure that every position is evaluated based on does it uh, does it, and to what degree does it promote the the mission, which is essentially to continue that healing ministry of Jesus Christ, which in a proximate sense is to provide merciful care for people, all
Yeah.
people, regardless of any other circumstance, as they write in Dignitas Infinita.
Yeah. I mean, and again, we're kind of bouncing between like some high level theory and concrete practices. I think this is an area where that they start to come together. Is we've talked about compensation and promotion. There are also tools that different ministries use to evaluate in the hiring process cultural fit, right? In many cases, for higher level executive leadership positions, there's a requirement that a mission leader is involved in the interview process where they're able to ask those questions. I think this is from the Ireland article, talks about making sure that you have ethicists uh, sitting in at the C-suite, level, or if you're in um, a performance line within a larger organization, wherever those bigger picture policy and practice discussions are happening, making sure that you have an ethicist and or a mission leader at the table. Those are practices that a lot of Catholic health ministries do. Um, and then there is also a discussion about training and education, which I think fits with both medical education, and the Combs et al. Article starts to get into that. That I think translates well into also formation, because we that's again something we do in Catholic healthcare. So the Combs article talks about in 2023 the Liaison Committee on Medical Education, which sort of sets the standards with the Department of Education for the medical degree in the United States. They added structural competency to required medical training in the United States. And then this article is reflecting on the ways in which those case studies and things have been brought into structural competency has been brought into medical education. So I think there are interesting takeaways for us in healthcare, Catholic healthcare as well. Is there anything from that article that stood out to you as particular, like good takeaways or insights?
Yeah, I mean, it's interesting. So this article is obviously different. The Ireland Miller piece and the Dan Finn are looking more at the organization and the structure that is the organization. This is looking, as you noted, more at getting medical professionals to uh, to really appreciate and further understand what structures their patients are encountering. What are the structures that are making their patients or leading their patients to be sick? It's another way to talk about this is the structural determinants or drivers of health.
Hmm.
But, I think what the Combs et alia study does is it kind of raises that up in a way that these medical professionals can receive education on identifying what are those barriers. If anyone in the listening audience has ever read Paul Farmer's work,
Mm.
specifically the pathologies of power, Paul Farmer, looked at this years ago and really saw that the biggest drivers of disease, and again, and this is the kind of at the burgeoning of the social determinants of health movement, were these structural impediments that people, if you give people a medication and they're hungry, they're malnourished, guess what? The medication doesn't work. So he ended up doing a study where he kind of tried to solve for some of those structural barriers, and guess what? It was a TB, a famous TB study he did. All the patients essentially that he ended up tracking were cured of TB, whereas before they had a terrible cure rate of about 50%.
Mm.
So what he did was something that was completely non-medical, which is just addressing the structures. And I think what the Combs piece is doing is raising that up for the medical community in this country today, is that there needs to be more competency and training around that. Um, we certainly don't want to overburden providers. I mean, they have enormous burdens already. But given the fact that what they're trying ultimately to do is not just provide treatment, but provide healing and provide wholeness and wellness. The only way that they can do that is by understanding the structures that lead their patients to get sick, stay
Hmm.
sick, return to the hospital with that illness again or that issue again. And so I think it's an incredibly important thing for us to consider, Tom. And I'm wondering if there were kind of reflections that came out of the piece for you as you read it and given your experience.
Yeah. Yeah. Well, it's a couple thoughts from what you just said. You mentioned not wanting to overburden providers, and that's absolutely true. They are um, stressed. I mean, there's just pick any study you want that's been published in the last 30 years. Like that's just known. What I find interesting, and this comes out in some of the results from the study in the Combs et al. Article, is that if done well, this is actually an enablement. It's more empowering for providers because some of the frustrations that can lead to burnout are this sense of being so constrained by the social conditions that I can't even help my patient because what can I do about these higher order structures, right? But this education starts opening up avenues to not just providers but their whole team, administrators and ethicists and mission leaders to ask those bigger picture questions about social determinants of health, and then start to take action on them. They don't get transformed overnight, but at least it starts to move in that direction. Um, and another thing that I thought of as you were talking is, most, I think, providers have moved away from this language, but in the past, it was very common for people to talk about non-compliant patients, like,
Yeah.
well, I'm telling them what drugs they need to take or activities they need to do to improve their health, and they're just not compliant, and then you get frustrated. And so I think this is another way in which I think as a even in our last podcast, we were reflecting on the state of the field, that there's a lot more questions being asked about justice and distributive justice and access and social determinants that the acute case analysis is taking place within this broader context. And we're getting more tools, I think, in the field and in practitioners' hands to ask those bigger picture questions. And I think when done well, that's empowering instead of feeling like our hands are so tied, you know?
It's a great point, and I think it is empowering, so that people begin to understand with greater clarity why it is that their patient population is made up of certain kinds of people, right, that are coming in with the same kind of issues.
Yeah.
And it really is an issue of justice. There's a Pope Leo is publishing or published a book this week, "The Power of the Gospel." I forget the subtitle, but he writes in that book.
Mm,
One of the quotes that I saw that was pulled from the book was, that we can no longer tolerate structural injustices.
mm,
Um, which he then suggests make and keep people poor, right? There's this, I mean, he has really emphasized structural justice,
mm,
embedding justice into structures, exactly as we're talking. But he's just following Francis, who talked about eliminating the structural causes of poverty in Evangelii Gaudium. Right? Francis understood that poverty is caused by social structures, not the only thing that causes poverty, but the predominant driver are structures that are unjust. And they're really just riffing on, as you noted earlier, John Paul II and his use of the term of the structures of sin, these ossified structures that lead to outcomes that don't befit human well-being. And I think it's important. One of the things that's interesting about John Paul is that the solution to all of this, all of these social structures that lead to death and diminished lives, is solidarity. This virtue of solidarity, where we are tied in with others, that we do not allow those groups to suffer alone, but rather we connect our lives to them. And I think you know, uh, Pope John Paul is inspirational. He did that, right? He did that in
yeah.
his own love, um, with his work, to help defeat the oppression that was the communist bloc. And so, we have these kind of witnesses to these solutions. And so I think, it reminds me of, if we really care about this work, and we do, and that these structures within Catholic healthcare are just. We also need solidarity, that we connect ourselves to the lives of the poor uh, in a way that can help to transform, that will enable us to begin to transform these structures in powerful ways.
I love that you brought it to not just the social structures or structural sin, but then the solidarity piece. I've been one of the things I wanted to share to make this concrete from that Combs article is an example, a case study that they use in this. This is a real case study from the educational program. It's almost like concentric circles. Like you look at just the acute clinical situation, and then you look at the social history of that one individual person, but then you look at that in terms of a broader structural and cultural view, and how that leads to practices of solidarity that clinicians and ethicists and others can really start to embody. So I think it'll be worth going through this. I'll try to summarize it pretty quickly, but um, so we start with like the standard medical history, right? Is in this case, this patient is diagnosed with untreatable cancer after presenting in the ED for pain, and this man's health quickly declines and is no longer able to safely travel or be transported. And then the other piece of that standard medical history in this case is the patient is distressed about the inability to travel, despite agreeing the fact that that risk is unacceptable. And in hospice reports that the available spiritual health support weren't very helpful for him because he only wants support from people of his own community, and he really is wishing that he could return home. In this case, was a reservation where he could be part of a community that would care for him in a way that felt part of his culture and aligned with his identity. So that, that you would get that in a standard case study. Now, if we do one of these social and structural case studies, now you kind of you take that next lens out into the social history. This man, it turns out, is indigenous person raised on a reservation, and really wants to stay in his home community and work and have his life there. But because of a lack of jobs being available, he's looking elsewhere for work. So he becomes a long haul trucker that's based out of a nearby city. Um, as he's engaged in that, he's starting to not feel well, but he doesn't have a lot of PTO built up. His medical insurance maybe isn't all that great or covering everything. So it's harder for him to seek medical care. So he's feeling this pain, but not following up on the symptoms. When he gets to the point of having a health crisis on the road, now we enter back into admitting in the ED, right? So there's already a broader social piece. But then they don't stop there in this case study, right? They back up even further and say, there's a history of colonization that is still impacting indigenous communities, including the one that this patient belongs to. So there are fewer economic resources for him in his home community. Um, and so there are fewer jobs, forcing people to leave permanently or just travel for work. And that just kind of keeps compounding throughout this patient's journey, right? Because he's forced, due to lack of local resources, to take this long haul trucking job that is out of his home community, but also requires him to travel more. Um, the physical toll of truck driving, sitting for most of the day, long hours, lack of control over schedule, could mask some of the underlying health issues or pain that he's starting to experience. Um, then you have poor labor conditions for different roles, right? Different jobs that people hold, with not enough PTO, not enough comprehensive health care. All of that now compounds into this patient, presenting and needing a certain kind of care and not feeling like his needs are being met. Um, so you kind of get a sense for how that can spin outward. But again, I think the power of looking through this lens that is more empowering instead of disempowering, or can lead us towards that sense of solidarity, is then to look at, how did people engaging with these case studies in their education program start to think about what they could do differently, um, as a system and as individuals, and even to the level of the political, right? So they weren't. He was unsatisfied with the spiritual care that they had, and so they were able to find specific kinds of, in this case, music requests that were based on his local indigenous traditions. They started to work hard to build then relationships through their spiritual care department with indigenous leaders who could connect with patients that come from that population, right? And that could look different based on where your hospital might be located, but making sure they had that deep bench. But then it could even go out to the community level where individuals that, because of their experience with this patient and these systemic issues, could start to get involved with advocacy efforts that are led by indigenous groups. Getting involved with local state legislation to maybe create more jobs in local economies, things like that. It also led them to think about ways they could engage with labor organizations who might have the capacity to affect policies related to long haul truckers and the number of hours they have or the kind of healthcare that they get, all the way up to the point of, advocating for tribal sovereignty and increasing in resources within indigenous communities. So you see how that goes from like the very acute clinical level to the broader community, the social, the community, and even potentially up to levels of like politics um, and who how you advocate for specific policies or laws. So that's a bit of kind of a lot, but I think it's a helpful. It helped make it concrete for me to think about how those get played out.
Yeah, I think it's what was interesting is that it really is consciousness raising for these folks, right? This kind of an
Yeah.
education really illumines the structural challenges. This is not their day to day concern, right? Are these social structures that
Yeah.
lead certain patients to come in? But I think the exposure is so important because it helps to explain the the situation that they're facing. And then, once you know the cause of something, this is very true in medicine. In the absence of knowledge of a cause of a condition, it's very hard to treat that condition,
Hmm.
right? We have, you know, we have not done a good job as a society of understanding the causes of disease and poverty. And I think this kind of work, this kind of education illumines causes so that once we know the cause, we can begin to work toward cures, solutions, right? And I think that is, it's kind of bringing us back to where we began. Everyone wants to transform structures. It says we need better, more just structures. Well, unless and until you understand what you mean when you say structure, you will not be able to transform those. And I think that's the value that we get with this work, whether it's
Yeah.
Finn or Miller looking at organizational ethics or Combs at Alia looking at education around these things. I think these articles help people in the field to further understand the what structures are and how they influence the well-being of their patients, which is ultimately the vocation that all the listeners are in,
Hmm.
serving those who are sick. So it leads me to, just ask you, Tom, are there any takeaways that you have from the work that we looked at this week?
Yeah. Oh, yeah. So many. We'll have to try to summarize it, but I, a point that you made earlier about not wanting to overburden providers, like I don't want listeners, especially if you're a provider, that the takeaway is now you also have to fix all of our social problems, right? Like that's it's a communal response where because of that solidarity, no one person is burdened, but it's more that we're empowered to respond and this, you know, case study didn't mention this, but these kinds of stories and cases could then also inform the community benefit process, right? And the community health needs assessment that all, not just Catholic providers, are required to do as part of their nonprofit status. So that's another way in which it could link in. Another takeaway that I want to mention that we'll put in the show notes, that same article mentioned that there's a series of case studies in social medicine published by the New England Journal of Medicine. I had never heard of this before, and having done, ethics grand rounds or ethics education or formation programs in the past, I would have loved to have known about this resource. So we'll put a link to that. So if you're ever looking for like a case study like that to bring to, whether it's to leaders or to clinicians, we'll put a link to that. Um, yeah, so those are some kind of concrete takeaways that I think are more immediate. We've mentioned throughout, being intentional about hiring, promotion, and compensation. That's an area where we can look at concrete policies and practices within an organization and ask that question. Are the incentives and penalties aligned with who we say we are, with our culture, with our desire to not only maintain the ministry in perpetuity, but also serve the most poor and vulnerable? And are we incentivizing people to do that? You know, Providing ethics education, I think, is always an ongoing piece, making sure that there are ethicists and mission leaders in the room where it happens, from the Hamilton perspective, in the C-suite or where those decisions are being made. Um, yeah, and then bringing maybe some of those case studies or these broader ways of looking at things into formation programs is another area where, how does our discernment about responding to needs of the local community, how is that impacted by stories like this long haul trucker or, every, as far from my experience, every hospital or every ethics committee or every care team has these stories that stick with them because they present these tragic examples of social determinants of health. And so this could be a way to almost make something good out of that frustration that providers and ethicists and clinicians experience in our work, because the need is always greater than the resources. So I think that those are some of the takeaways for me. Yeah, what about you? Where do you see this playing out?
The more that I've studied organizational ethics, organizations in general, the more I think that we underappreciate the power of organizational structure. It's not exciting. It's not
Hmm.
kind of these moral dilemmas that you could debate for hours in a seminar. But I think it doesn't get the attention that it deserves. Um, because those as I started with that example of the palliative, whether the hospital had palliative care or not, made an enormous difference,
Hmm.
right? Um, and I think looking at like what positions exist, how do we, what's the description of the position? What is the org chart? Who reports to whom? All of those things are basic, but that is the meat and potatoes of organizational ethics. Um, and I think we medical ethics historically, healthcare ethics historically, has tended to focus on the macro level, so national health policy, or the micro level, individual bedside case ethics. The meso level, that middle level of organizational ethics, has been under theorized throughout the history of healthcare ethics. And I think that's ending or has ended to a degree. But there's a lot of work that needs to be done, especially for mission-driven organizations like Catholic healthcare systems and hospitals. Because what a mission-driven organization has to do is align all of those incentives to the mission. You show me what you reward, and I can show you what you value. That
Hmm.
is, I think, the central takeaway that I get the more that I look at this, and that you want to be able to see that the mission is reflected. Now, certainly, we need financial stability. There needs to be margin, all of that. But again, that serves the ultimate mission, which is the care for patients, the promotion of dignity, enabling persons to flourish, and then continuing this healing ministry of Jesus Christ. So, um, yeah, it's not as exciting as those cases, Tom, but I think it's in many ways more essential for Catholic healthcare to consider and and to put energy into.
Yeah. You know, I think of this in relation to the founding stories that we tell in Catholic healthcare. The day to day of what mostly women in this case, religious, did to found and then get these ministries to a place of flourishing. Like you said, it was not that exciting on a day to day level, but they understood that directly translated into the care that people who needed it most were going to get. And so I a joke that I used to tell with a good friend of mine who's also a mission leader, then when we work together, is we would say, sometimes it feels like we're shoveling fog, like building culture. It's hard to make tangible. You know it when you feel it. When you're in a place that's really well aligned, you know it, and when you're in a place that's really not well aligned, you know it. But what I think some of this analysis does, and the tools of critical realism and organizational ethics and structures is doing, it can feel maybe a little bit less like fog and more like, oh yeah, these are the tangible things that we're doing. The change is still kind of slow and gradual, but I think you're right. We do need that meso level engagement, because that's what sustains it. So maybe there's a little word of hope and encouragement in there for those of our listeners who are in the grind every day, because it's not easy work, but it's real and tangible.
Yeah, it can be done, and I think we tend not to think of HR being a place of intense moral reflection, but how those
Oh, we're
performance
gonna get complaint
evaluations are
letters
being written
from
up.
HR.
Yeah, what's being evaluated, what the HR professionals are writing up in terms of what's being evaluated, how it's being evaluated, what's being measured. It doesn't jump off the page as a mission critical um, aspect of the organization. Maybe for some it does. I think for me it always hasn't, but I'm convinced that it absolutely is. It's at the core of the organizational mission and ethical character, moral character of our organizations, whether it's in Catholic healthcare, whether it's in education, you name it.
Yeah,
But yeah, we'll leave it there, Tom.
I think
There's no
so.
we
Yeah.
say, but I think
Word of
that's
hope and carry on for all of you out
Yeah.
there doing that good work.
that's
Yeah.
right. So for Tom Bushlack, I'm Dan Daly, and this has been Ethics on Call. You can find this podcast on YouTube, Spotify, Apple, and our website, theologyandethics.org/podcast. If you're on one of those podcast platforms, would ask that you follow or subscribe to our page and leave a 5-star review and some feedback about the show. Would love to hear from you. We will talk to you soon.